non-invasive modality that with this growth of its work, all indications are slowly being very meticulously studied by the FDA, and each and every now and then we're getting an approval from the FDA to be implemented either in the United States or even outside the United States. So I'm considered one of the believers of HIFU, ultrasound therapy, and I think the span is growing, people using it and implementing it. I would like to introduce my dear friend, Martijn Boomsma. He's professor of interventional radiology in Asala University in Netherlands. He's going to give us talk about screening and re-intervention after 3 years MRI-guided treatment for uterine fibroids.
Thank you, Mohammed, for the kind introduction. Thank you, everybody in the room, for paying attention to this talk. When I was a young boy, I made a paper about Egypt, and well, finally a dream has come true. So I'm here after 35 years. So, and I hope I can make you acquainted with this beautiful technique, which has some difficulties in being adopted by the clinics. So this is not only my talk. It's my talk of my very talented PhD student, Loes Knorre. She works with me in the hospital and works on several HIFU projects. So we'll talk about HIFU. More important, the right patient for the right technique, screening. We will talk about results. I think that's very important because we often study things not in a very structured way, and that hampers clinical adoption. We should do things better, we should do it together, and we should do it quicker. So what is MRgHIFU? A quick recap. HIFU uses convergent ultrasound beams so that at a certain focus point you can heat up the tissue and denaturalize the proteins and induce apoptosis and necrosis, or in some cases achieve devascularization. And that's being done with an extracorporeal transducer, and you can do it ultrasound guided or MR guided. And today I will talk to you about the MR guided approach, because I think it has some advantages, but we all know it also has some disadvantages. So the patient is on her belly, on the table in the case of fibroids. The transducer is in the table and the MR machine is around her, and she is being sedated. So she is relatively conscious. Okay, so this is how the console looks like. The blue dots are actually cylinders, or sometimes we call them torpedoes, or you can call them bullets, but I think it's more respect to pronounce it as cylinders. You can adjust the size of these cylinders, and that makes a distinction in how quickly the tissue heats up. But it's always a trade-off. Smaller cylinders heat up quicker, but it will take you more time to reach a certain volume. And we use the MR guidance for anatomical mapping, but we also use the MR guidance for temperature mapping, and that gives you a very strong controlled situation that you will not have any side effects, such as burning the plexus in far field or have severe grade 2 or grade 3 abdominal burns. So a great example, we always show you the best cases, but don't worry, I will also show you the not so great cases, because as everything, the world is not binary, so is not MR, so is not MRgHIFU. So you see here uterine fibroid before HIFU, low 2.2 signal intensity, and after T1 gadolinium enhanced imaging shows you that there's no enhancement of about 90 to 100% of the lesion. You can also treat other female diseases, and I would like to underline the fact that women are undertreated, under-recognized, and I think that has to change. Adenomyosis is also a disease that affects women, is not always acknowledged, and we can treat it also with HIFU, also with medication or other surgical interventions, but it's very elegant and it preserves fertility. increasing problem with cesarean sections due to several papers out there gynecological surgeons have embraced the C-section for good reasons, but maybe sometimes also for medical legal issues. Anyway, we don't want to accept any bad outcomes anymore, and we feel that cesarean section is the way forward in many cases. But it has a drawback that you can have endometrial cells in the scar tissue in the abdominal wall, and there is not much you can do about it except for surgery. But how great would it be if you could do this non-invasively? You can also treat deep pelvic endometriosis by a rectal coil, but I will not go into that in further detail. Other indications, which maybe another speaker will talk about, is MRgHIFU to treat essential tremor, obsessive compulsive disorders, depression, or even addiction. Another study which I'm involved in is treating metastasis to the bone in a palliative daycare setting. Some patients are refractory to radiotherapy, or if you're not treated already by radiotherapy, it will take you 10 to 14 days to have a positive response, and with HIFU you have immediate pain relief. So we are investigating that in a European funded trial called Further. Okay, back to fibroids. So there are contraindications. You don't want too much fat to be there in the subcutaneous for near-field heating, but it also increases the distance to the backside of the fibroid, and MRgHIFU has a certain limits. You don't want to exceed 10 to 12 centimeters. So we have achieved in the ISALA larger inclusion rates due to the fact that we have developed more manipulation techniques in order to have the uterus antiflexed and have the fibroid in more close contact to the abdominal wall without interposition of bowels. So you don't want them to be too small, you don't want them to be too big. Too small because of the technical issues. Too large is not very favorable because although we will treat the patient, the fibroids will shrink, but it will not definitely go away. So screening the right patient is very important. So the classic Funaki classification is well known. You assess this by T2 weighted imaging. Funaki 1, low T2 signal intensity, lower than the abdominal musculature and lower than the myometrium. Funaki 2 is higher than the abdominal wall muscles, but not higher than the myometrium. And in Funaki 3, you have a high T2 signal intensity due to more vascularization. We don't really know exactly what's going on in this fibroid. Anyway, we get more heat sink and it's more difficult to heat them up. So traditionally, we should not treat Funaki-free patients. So this is an example of a homogeneous enhancement on the left and inhomogeneous enhancement on the right. And I will go back to the screening with means of Funaki classification. So this seems very simple, but nothing is simple in medicine. All questions always and never are wrong. So in this case, Funaki A, we can treat them very well. Funaki 2, we can treat them most of the time very well. But Funaki 3, most of the time we cannot treat them well. But the point is, a lot of women present themselves with fibroids that are not actually Funaki 2 exactly, or exactly Funaki 3. You get these kinds of patients. Okay, this is a Funaki 3. I won't go into detail, but we had a broad inclusion in the beginning in different studies to get acquainted with this technique. But we get a great non-perfused volume of 100%. So it was a Funaki 3. We should not include the patient, but we got great results. This is a patient, Funaki 2, 3, but no enhancement at all. We were unable to heat it up. And nobody up till now knows what exactly is the reason that it's not working. There are many groups out there with multi-parametric prediction models, AI, deep learning, but no definitive conclusion yet. So we don't have a right prediction model. This is Funaki 2 with hyperintense parts, looks different than the other ones we've seen before, but we got a great non-perfused volume, 90%, great results. Another one looks a bit like it, bit different. We're not able to heat it up very well. But we do know one thing. We should treat these adenomas unrestricted. So you should go for 100%. In former days, we didn't do that because of issues of safety or whatever, but we're not doing that anymore. You need to go the extra mile. You need to go for the 100%. Because if you look at it systematically and you look in the literature only at unrestricted protocols, that means you will go for ablation, full ablation, and you really look at the papers if they actually have achieved that. And there's the rub. Most papers do not really describe how they achieved it, to which extent this goal. But anyway, if you ask me, Martin, in general, how does it work? Well, you get a volume reduction of 40%. You don't have any complications. This is great. This is the unique selling property. You get live birth rates of 73%. The symptom severity score drops with 60%, and the quality of life of the women increase with 30%. Reintervention rate, very important when you talk to reimbursement. Different figures are around out there, but I would say the 3 years follow-up is about 20% reintervention rate. If you do that US guided, the evidence out there is 53% after 5 years. For example, uterine embolization, also a well-known technique, after 3 years was 17.8%, but after 10 years, it's 50%. So this is something we should keep in mind. What did we do in the past? We did myoma screening studies. We put every woman with a fibroid on the table and we looked at it. And we treated. I had a PhD student, Ines Verpalen. She was furious. Like she treated all patients. She manipulated. She had all kinds of tricks. And that's why we can say something about the do's and the don'ts in HIFU. But we took a look at these broad inclusion patients. There were patients like this. I don't think this is a very suitable patient for HIFU. I don't think this is a very suitable patient for embolization. I think this is a good patient for hysterectomy. So what did we do? We had 100 fibroids in 79 patients because we excluded the first 25 of a learning curve. There were all technical reasons why sometimes things didn't happen. We were learning. So we had patients with HIFU treatment without persistent treatment failures, and that came down to 65. And when we look at them, no reintervention rate in 70% and a reintervention rate of 31%. So that would say, oh God, this is very bad, right? But this was still in the days of that we wanted to give this treatment to more women because the women really want a non-invasive treatment. They like to preserve their uterus for various reasons. So if we apply the strict screening protocol, which we do now for the MOHP study, and I will come to that later, the MOHP study is a randomized clinical trial which we are conducting, the reintervention rate at 3 years drops to 84%. And you are the first people in the world to hear these numbers. This is a premiere, especially for Cairo. So, going back, MRgHIFU is non-invasive. It has low to non-complication rates. It's day care. You go home immediately. You preserve your fertility. Extremely short recovery times. It's very sexy. But, there's always a but. Not every patient is suitable. MRI capacity in the Netherlands is an issue. I can assume it's also an issue in Egypt. And there's no reimbursement yet. And that hampers the clinical adoption. So, screening is essential. It's especially appealing for women who still have child wish, but we need to find a strict screening protocol to reduce reintervention rates. And we need, and this is always hard work, we need to work on the long-term cost effectivity, and you always need to compare it with standard clinical care. And that's why we developed the MOHP study, which we're conducting. We just enrolled our first 100 patients. We need to go for 180. It's a national randomized clinical trial in the Netherlands, which women are randomized 2-to-1, 2 in the HIFU arm, 1 in the other conventional treatment arm, the control group. And that consists of patients who will undergo, by their choice, that's why it's called My Choice, ladies, embolization, myomectomy, or hysterectomy. I'm here for any questions or suggestions. Oh, but maybe, Professor Forzi, you want to do the question in the end, maybe, yes? So I'll keep on going. There's a bonus case here for you, especially, we are just submitted it. You're the first ones to see it, the second premiere, just especially for Cairo. You see here a myoma. It's a Funaki 212. It's a good patient. We get extremely good non-perfused volume, probably because you devascularized the tumor. That sometimes happens, that's very important. But the patient was in follow-up for 3 and 6 months, and she had tissue loss and dysmenorrhea, complained during her menses, but she didn't have any more menorrhagia or palpable uterine fibroid by the gynecologist. And at 6 months, the tissue loss persisted, but the dysmenorrhea stopped and there was no more menorrhagia. And what you see here is actually intracavitary expulsion of a submucosal fibroid. It happens in nature when you don't do anything. Only in 0.1% of all patients with fibromas. You get necrotic discharge, tissue loss during the menses, menorrhagia and dysmenorrhea. And this is caused by the difference in shrinking of the fibroid compared to the myometrium. And this can result in vaginal expulsion. Classically, no treatment is needed unless heavy bleeding, heavy pain, or signs of infection are there. And complication can result, this complication between brackets, can result in symptom reduction or even disappearance of the myoma. Thank you very much.
Thank you, Professor Martin.